Now, when we talk about identifying CHF on a chest x-ray, remember that there's certain things that would tip us off on a chest x-ray that the patient's got CHF. The first one is obviously going to be cardiomegaly. Remember, when we talk about cardiomegaly, cardiomegaly is defined as the heart being greater than 50% of the thoracic space. So for instance, if we go from rib to rib, if this space is X number of centimeters wide, when we look at the cardiac silhouette, if the cardiac silhouette is greater than 50% of that number, then we would say the patient has cardiomegaly. And remember that that has to be in a patient who's sitting up. Patients who are laying down, their heart is almost always going to be greater than 50%. So in order to say that there's cardiomegaly based on the chest x-ray, that chest x-ray needs to be taken sitting up. Other things that would tip us off that infiltrates in the lungs are truly CHF are things like equal distribution. Remember that people don't get CHF in one lung, they get CHF in both lungs. Other things we would see are evidence of pulmonary vascular congestion, and we talk a lot about this in the respiratory section when we talk about management of ARDS. Remember, with CHF, the whole problem is a backup of blood, and because there's a backup of blood, we're going to see that blood vessels engorge first before we actually start to see interstitial leakage of fluid into the interstitial space of the lungs. So the way that we can see that on a chest x-ray is, first off, we'll oftentimes see something called a butterfly pattern as the patient first starts to get CHF, and the butterfly pattern is a pattern that looks almost like the shape of a butterfly around the great vessels, because CHF is going to work its way out. It's going to go from the heart out towards the periphery. Now, as that butterfly pattern becomes bigger and bigger and bigger, what we'll actually see is that the movement the backup of blood in the periphery actually creates something called curly A and curly B lines. And these arrows here are demonstrating curly A and curly B lines. Curly A and curly B lines oftentimes on a chest x-ray look almost like cobwebs. It's like little visible lines all over the place in the white spaces. Those visible lines are blood vessels that are engorged. So they tip us off to the fact that this is CHF, and this kind of helps us to differentiate CHF from, say, like ARDS or pneumonia, bilateral pneumonia, or something like that. Okay, so remember when we were talking about CHF, we said that there was a progression. We said you've got CHF that becomes decompensated CHF, and finally it becomes cardiogenic shock. Well, where's the cutoff between decompensated CHF and cardiogenic shock? The answer is actually very clear. It's the objective evidence of shock. And probably, again, the most definitive way to tell whether or not somebody's got shock is whether or not they've got an acidotic blood gas and they've got an increase in their lactate. Cardiogenic shock is the result of lactic acidosis. It's an oxygen delivery problem. It's a stagnant hypoxia. The patient's heart is not effectively contracting, so blood is not being perfused to the cells the way that it needs to, so the cells go into anaerobic metabolism and they start to produce lactate. So if we wanted to tell whether somebody's in decompensated CHF or cardiogenic shock, probably the most sensitive way to tell would be to look and see if the patient has lactic acidosis. If their lactate is greater than 4, then we know absolutely positively they're in cardiogenic shock. If their lactate is normal, their blood gas is normal, they're not acidotic, but yet we're seeing an increase in symptomology, like the patient's got pulmonary edema and things like that, that probably is not cardiogenic shock. That is probably just decompensated CHF. And the reason why this is important is for years we focused on the blood pressure as a mean point to defining cardiogenic shock. Like when most of us went through school, we were taught like, well, it's CHF until the patient's blood pressure gets below 90, and then when it gets below 90, that's cardiogenic shock. Well, that's not the case. We know that we now know that's not the case. Cardiogenic shock is about whether or not there's adequate tissue perfusion and adequate tissue oxygenation. If you've got somebody who normally sits at a blood pressure of 160 systolic, when their blood pressure is 120 systolic, they may be in fulminant cardiogenic shock. In contrast, if you have a little old lady whose blood pressure normally sits at 90 and the patient's in decompensated CHF with a blood pressure of 70, we may not have shock. That patient may have a decrease in their blood pressure, but it's not enough yet that they've actually started to develop lactic acidosis and metabolic acidosis. So the decision whether we're in decompensated CHF or cardiogenic shock is not really about the blood pressure. It's about whether or not there's objective evidence of shock. So do we have an increase in the lactate? Do we have an acidotic blood gas, a metabolic acidosis blood gas? Do we have decreased renal output? Do we have decreases in the level of consciousness? So on and so forth. Now, once we've made that transition, once we move to the point where we're actually starting to see objective signs of shock, when we're no longer in decompensated CHF, but we're actually in cardiogenic shock, we are now officially stuck between a rock and a hard place. Because remember when we talked about management of CHF, the big thing we said we needed to do for patients with CHF is we needed to decrease their afterload and improve their hemodynamics. And remember that most of those drugs that we use for decompensation of for CHF and decompensated CHF, like the nitroglycerin, the Lasix, the ACE inhibitors, all those things decrease the blood pressure. Well, when my blood pressure is so low that I've now pushed myself into cardiogenic shock, I no longer have that option. I no longer have the option to decrease blood pressure. And so the only thing that I can do for this patient is increase their blood pressure. And the way I'm going to increase their blood pressure is with vasopressors. So I'm going to start using things like dopamine, Levophed, things like that. Now, the big problem with those drugs is the way that those drugs work is they increase the systemic vascular resistance. And we've already talked about when I increase systemic vascular resistance, I actually increase the workload on the heart. So when I've got cardiogenic shock, I'm now stuck between a rock and a hard place because I can't lower the patient's blood pressure anymore because they're already hypoperfused. And if I give the patient pressors to increase their blood pressure, yeah, that might make me feel a little bit better and that may make their blood pressure look nice and pretty, but I'm doing that at the cost of damaging their heart, so I'm officially stuck. And that's the reason why patients in cardiogenic shock have an 80% mortality rate. So when we talk about the actual management of cardiogenic shock, what do we do for it? Well, we're stuck between a rock and a hard place, so in the immediacy, in the short term, one of the things that we need to think about is we need to think about getting the blood pressure up. So we have no choice. We need to start the vasopressors. But remember, when we start those vasopressors, we're making a conscious decision that our short-term goals are more important than our long-term goals. And if the patient's got cardiogenic shock, obviously our short-term goals are more important. We need to get the blood pressure back up by whatever means we can until we can fix it. But vasopressors in and of themselves are not the cure for cardiogenic shock. We know with cardiogenic shock, the disease is the pump. So really we have to focus on what can we do to augment the pump. So when we talk about cardiogenic shock, we said that 80% of the time patients are going to die from this. So who are the 20% that live? Well, it's actually pretty simple. The 20% that live are patients that have readily reversible reasons for their cardiogenic shock, or patients in which we can provide some augmentation of flow through some other means. So who would that be? Well, the classic example of the patient in cardiogenic shock who has a high probability of survival is the patient who's in cardiogenic shock because they're having an acute MI. We know now how to treat that. We know fairly easily how to treat that. We rush the patient off, we take them to the cath lab, we get rid of the clot, we put in a stent, lo and behold, blood flow comes back and the heart starts to work again. So for those patients, cardiogenic shock is absolutely positively survivable, assuming that we can get them reperfused in time, that we can recover that myocardium. Well, who else survives cardiogenic shock? Well, the other group of patients that survive cardiogenic shock are the patients that we can bridge until we can do definitive treatment, and a lot of time definitive treatment means actually getting a heart transplant. So what do we do to bridge those patients? Well, this is where our surgical options come in. And surgical options might be things like putting in a balloon pump. It might be things like putting in an LVAD. Those are the things that are going to buy us time in order to be able to definitively manage the cardiogenic shock in the form of a heart transplant. Now, interestingly enough, when we talk about LVADs specifically, when we look at LVADs, they're designed to work for up to about 100 days, but we've actually seen that we've put LVADs in people for a lot longer, and they've actually done really, really well. And we've seen that LVADs can actually decrease the workload on the heart so much, can actually augment cardiac output so much that patients actually start to heal their heart. Their heart actually starts to get better. And so when we decide that a patient needs to go for a heart transplant, oftentimes what that means is the patient's going to go on an LVAD first as a bridge, but it's not uncommon that we see that when we put those patients on an LVAD, we actually see over time, over a period of weeks to months, that they actually do so much better that they actually become ineligible for a heart transplant because they do so well with the LVAD. We actually see the heart start to heal itself. So those are kind of the only strategies we have for managing cardiogenic shock. So again, in the immediacy, in the short term, big thing is vasopressors to get the blood pressure up. Then we want to look at a surgical option if the patient's not amenable to cardiac stenting because it's ischemia. If they are, then that's the thing we're going to do. We're going to stent them. But if that's not the case, then we look at temporizing measures, being things like a balloon pump or an LVAD, until we can definitively manage the patient's heart by a surgical means like replacement. Okay, let's take a break here.
I'd come for you, no one but you. Yes, I'd come for you, but only if you told me to.